And the next lecture is about unhappy patients and management of unhappy patients. Lecture is Professor Олівер Фіндль, President of the ESCRS and the Chief of Department of Ophthalmology, Hanumi Hospital in Vienna.
Dear colleagues, I will speak about managing an unhappy patient, and in this case I will be focusing really on presbyopia correcting IOLs, because that's where we have more unhappy patients than we usually do when talking about cataract surgery. These are my financial disclosures, none are relevant to this talk. So there are a few things we need to do, and especially when we talk about presbyopia correcting IOLs, and I want to try to address one after the other. The first one is we should talk to the patient. Of course we should talk to the patient. This may be the most boring slide, but it's actually also the most important slide. You need to find out what the patient wants and really needs. The occupation, are they nighttime drivers? What hobbies do they have? What are the visual needs? And then you need to translate that into the distances which they're important to them. And you need to understand their expectations. If they have very high expectations, you need to be quite aware of that. Explain also what each type of IOL can do, is capable of achieving, and also limitations of the technology. And of course, you need to talk about the side effects. And you need to assess the patient's personality, which is not always easy within 10, 20, 30 minutes. Are they perfectionists, for example? And that is important. You can find that out when you actually do refraction yourself or somebody else at the refraction. Are they perfectionists? That may be quite important for the way you deal with this patient. Then you need to examine the patient and especially look at the cornea, at the slit lamp, corneal topography or tomography, maybe even aberrometry. This is a small decision tree for abnormal corneas. There are some which have irregular astigmatism, for example, which may be treatable, like pterygium or epithelial basement membrane dystrophy, Salzmann nodules. In that case, you would treat that first and then see and recheck your topography, for example, to see whether it becomes more regular. If the cornea turns out to be quite regular, then it's possible, for example, to use an EDO or FIOL. If the irregularity persists, then you may want to go for a monofocal plus or small aperture lens. Of course, there are also some non-treatable irregular astigmatism causes, like keratoconus, for example, where you should really go for a monofocal lens or maybe actually for a small aperture IOL. But who is the elephant in the room? It's really dry eye disease, of course, ocular surface disease. And here you need proper assessment, especially to have good biometry. You need to check the Myers of your keratometry, the actual raw data, and you may have to redo the biometry 1 or 2 weeks after intensified therapy. So it's quite common to have obviously ocular surface disease in cataract patients. And many of them are actually asymptomatic, but still have some corneal staining. And many of them also have abnormal osmolarity, for example. So this kind of testing of the ocular surface of asymptomatic patients may be quite important, because you may have symptomatic patients after surgery, and then that of course leads to reduced visual function. So here an example of a patient with dry eye disease, where we actually don't get any keratometric readings in the first reading, and then we get quite different readings in the second and third. And if you look at the actual Myers, what you can see is there's some very slurred reflexes in the keratometry. So what we do now is intensive therapy, in this case for 1 week, treating the surface, and you can see that the Myers are much better, and now all the Ks also match. And this is especially important when you want to address astigmatism. So the question is, should you use artificial tears during the pre-operative assessment? So you have somebody with ocular surface disease, you're doing your biometry, the biometry doesn't look reproducible. Then actually this study showed that if you use drops, lubricating eye drops, and then redo the biometry, this will actually change the cylinder and also implantation access for toric lenses quite significantly, especially in those patients with a poor breakup time. Here a study actually from Vienna, looking at lubricating eye drops prior to keratometry measurements. And what they saw is that there's a lot of fluctuation in the first few minutes after having instilled those drops. So it may be quite important to wait for several minutes and then redo the biometry. This is another study we did looking at patients with meibomian gland dysfunction and looking at stability of biometry. And what we did is we actually did a thermal pulsation therapy with the LipiFlow system and looked at the patient after 2 weeks and 3 months, so quite intensive therapy. We did it on one eye and had the other eye as a control eye. And what we did see is that even though the spherical power of the IOL didn't change with that therapy, definitely the astigmatism axis measurements did change. So the patients also found the therapy to be beneficial, but the change in biometry was only really for toric IOLs. So if you have a patient you're treating with ocular surface disease and that significantly improves, there's no corneal staining, much improved breakup time, and good regularity on the topography, then probably you can proceed with all kinds of presbyopia IOL options. However, if you only partially have improved ocular surface disease, then you may want to go either for non-diffractive EDOF lenses or even better for monofocal plus lenses. And again, you need to be need to inform the patient about these problems that they may have and that they will need to continue to treat their ocular surface disease. Now, what about a patient who also has concomitant glaucoma? Should we use these kind of IOLs with presbyopia correcting technology? And I think really the important point is how severe is the glaucoma, and also how strong is the desire, of course, of the patient to be less dependent on glasses. If it's a patient just with ocular hypertension or very mild glaucoma, then I think it's one thing, and also the well-controlled IOP and with full visual fields. On the other hand, if you have somebody who already has pronounced glaucoma, and also keeping in mind that glaucoma patients may also have a poor surface of the cornea because of the drops they're taking regularly, then in those cases, I think you should try to avoid presbyopia correcting IOLs. In patients with AMD, I don't use presbyopia correcting IOLs at all. Now, the next point is good planning. Really important, of course, with presbyopia correcting IOLs is to really hit emmetropia. So you should use optical biometry, maybe do multiple K readings, use also optical corneal topography or even tomography to check the regularity of the cornea, to get a second opinion of the amount and the axis of the astigmatism. And of course, you should use modern IOL formulae and ideally compare several formulae and then try to find the best fit. Now, we have a lot of very good formulae online. For example, the K6 by Cook, the EVO formula, the Hoffer QST, the DGIS, Pearl DGIS formula, the Kane formula, the Hill RBF, which is an AI-driven formula, or the Barrett. So you can go online and use all these formulae, but that's quite cumbersome because you have to enter the data for each of these. So the ESCRS has now come up with the so-called ESCRS IOL calculator, which actually gives you the opportunity of using all these modern formulas, but you just have to enter the data once. And we use a technology called web scraping, and you may know this technology from, for example, trying to find a flight to go from A to B. And what you do is you enter that into the web, and then the technology called web scraping looks at different sites of different airlines and tries to find good solutions for you. This is what we're doing with the ESCRS calculator. So you enter the data once, and also the constants used for the IOL will actually be updated from the IOL.com database on a daily basis. And then you get an output, and you can see all these different formulae right next to each other, and you can compare them directly. So I think this is quite helpful, especially for patients where you're going to do presbyopia correcting IOLs. So this is the website. It's free of charge for everybody, and I think you should try to use it. I really highly recommend that. So of course, good planning, hitting emmetropia, you have to address astigmatism with toric IOLs. And we know from studies, for example, from Hayashi, from Japan, that if you use multifocal technology, if you have residual astigmatism after surgery, then visual function decreases quite significantly, even with low amounts of astigmatism. And that is something you need to address. Here a study which was actually quite surprising to us. This is a study by Steve Chalhol, a very large study on nearly 35,000 eyes. Most of those had presbyopia correcting IOLs, many different centers, all femtocataract surgeries. And you had a quite significant amount of patients, of about 30%, which had one or more diopter of astigmatism. And what you can see here is that, of course, with increasing astigmatism, the visual acuity decreases. But interestingly, the actual unhappy or very dissatisfied patients, of course, also increase with residual astigmatism, but not as much as you would expect. We also did an ESCRS clinical survey where we interviewed about 1,000 or 1,200 of ESCRS delegates every year to find out what their practice patterns are. And here, this is the result of what ESCRS members believe is the kind of residual astigmatism you should have if you're using a presbyopia correcting IOL. And most think that, this is 2/3, think that between half and 1 diopter is still okay, and more than that, you should try to avoid. Now, what if you have tried to address residual astigmatism, but you still have some residual refractive error in general? This can be spherical or astigmatic. There are different solutions or which you can attempt, for example, using piggyback IOLs, which may be more accurate than IOL exchange, but may also cause a little more glare. The IOL exchange, of course, is an option, but maybe a little more risky. And of course, you may use excimer laser to actually give you probably more accurate results. However, not every surgeon has access to these lasers. It may also be that EDOF IOLs, may be a little more tolerant to residual refractive error than, for example, trifocal technology. This is a study actually by Beatrice Koschner, where she looked at residual cylinders of up to 0.75 diopters after implanting an EDOF IOL, and had only mild impact on visual acuity. Another study by Coronis showing similar results. Once you have taken care of all these issues, what may happen is you may get some PCO, posterior capsular pacification. And we know that with presbyopia correcting IOLs, even very little posterior capsular pacification can already give you more starbursts, more glare, some waxy vision. And so therefore, the IOL technology obviously plays some role here. So in these cases, obviously you may want to do a YAG capsulotomy much earlier than you do otherwise with a patient with monofocal IOLs. However, you have to be a little wary about that because a patient may be unhappy because of these side effects. And you're not sure, is it because of the PCO or is it actually because of the IOL technology? And of course, once you have done a capsulotomy, the IOL exchange will be much more difficult and you will have to do an anterior vitrectomy, and then you will not be able to put a lens into the bag anymore. So timing here is going to be a challenge in some of these cases. Now, what about patients who, everything looks pretty fine, but they're still unhappy? And we know that neuroadaptation is something which is quite important for multifocal technology, because we have superimposed images of the different foci, which reduce contrast. And we know that visual cortex activity increases 3 weeks after bilateral implantation of multifocal IOLs. And this is actually a study which was also co-sponsored by ESCRS, by Andrea Rosa. We also know that symptoms of dysphotopsia appear to improve 3 to 6 months after surgery and even up to 12 months. So this is something obviously which needs to be discussed with the patient. And also, neuroadaptation to multifocal IOLs seems to happen a little smoother and faster when both eyes are operated. That's why we tried to operate both eyes within a short time interval, if possible. And also exchanging a multifocal lens for another multifocal lens with a different optical profile has been shown to be successful in a study by Jorge Alio. Now, if you need to do an IOL exchange because the patient is really unhappy, then obviously you can do an IOL exchange against a standard monofocal lens, or maybe a monofocal plus, or you can induce a mini monovision. And you may think about using, for example, a non-diffractive EDOF lens or EDOF lens in this case. This is a study, again, by Steve Schalfhorn with a huge number of 9,000 eyes with trifocal IOLs. 92% were within plus or minus 1 diopter or spherical equivalent, and 81% actually achieved a very good binocular unaided distant visual acuity. But about 1.7% were very dissatisfied. So 55 IOLs were exchanged because they had glare and ghosting as the main symptoms. And 41 of these, the ion exchange in the dominant eye was actually sufficient to alleviate the symptoms. And only in 7 patients, they actually exchanged both IOLs. So you may want to exchange just the dominant eye first, and that may already result in a much better situation. So to finalize, there are no perfect outcomes. Every component is critical to have a satisfied presbyopia patient. So you want to obviously, if you miss the refractive target, you need to correct it, you need to take care of that. If you have nighttime driving issues, you may hope for neuroadaptation to kick in, otherwise you may want to do an exchange. In patients with glaucoma, AMD, or for example diabetic macular edema, I would be very restrictive in using presbyopia correcting IOLs. And of course, ocular surface disease is really common, as you know, so you should diagnose and manage it before surgery. And in general, under-promise and then over-deliver, that's probably something which is always important to do. Thank you very much for letting us take part in this symposium, and I'll try to be there for questions if those arise.
Thank you so much, dear Professor Oliver Findle.